And 6 to 8 weeks later, we can selectively and electively remove this tooth from the tuberosity. We want to avoid this kind of scenario. Here in an elderly patient, too much force was applied and the whole segment chipped off the alveolar process. How to avoid it? How can we really avoid this? I always recommend our students and residents, a good way to actually minimize the trauma is to do a good soft tissue flap, to remove a proper amount of bone and section the tooth. Because we learned from the past. We learned that a conservative close technique sometimes even exceeds the morbidity of a controlled surgical extraction. We apply an old principle. Even emperors like Julius Caesar applied this principle. Divide and conquer. Divide et impera. We section the tooth. We divide the problem into smaller problems. We conquer it by solving each problem and combine results together to solve the original problem. So if there is a problem with the tooth extraction, think about sectioning this tooth. Because root fractures, uncontrolled fractures of the root are the most common intraoperative complications. Typically, they happen in long, thin, curved, divergent roots. So proper exposure, proper removal and section of the tooth can help us to minimize that complication. But it still happens. And then we have to think about, should we leave that root in the socket, or should we remove it? Well, if we leave it in the socket, we can face two different situations. Either it heals in, no problems at all, or it doesn't heal in. It shows us these radiolucent areas, and the patient has symptoms. So what should be our thought process when we are facing a root fracture? Well, in general, the surgeon always has to balance the benefits of surgery versus the risk of surgeries. And yes, at least 3 conditions must be fulfilled so we can decide to leave that root fragment in the socket. The fragment should be small, should be really deeply embedded in the socket and not superficial, and should not be infected. These are the minimal conditions which have to be present before we decide to think about leaving that socket in place. Yes, it's all about evaluation of the risk of surgery. What are these kind of conditions? The risk of surgery is greater than the benefit. Well, the tooth removal should not be performed. If we cause a lot of destruction of the surrounding tissue, if we are endangering important structures like the inferior alveolar nerve or the mental nerve, or we have a higher risk of displacing that root tip, for example, into the maxillary sinus or in other tissue spaces. And if we decide to leave that root tip in the socket, we always should inform the patient. We should have a radiographic documentation. We record it in the patient chart, and we follow up with that patient in several sessions to make sure that this root tip is healed in without any problems. Because sometimes what can happen, if we try to recover a fractured root tips, we can perforate an anatomical structure or even displace it. Typical sites, really, the maxillary sinus, infratemporal fossa, and some spaces around the mandible. I will give you some examples. Like here, this root tip was tried to be recovered and was displaced in the floor of the mouth. Here, in the maxillary sinus. Here, the entire tooth was displaced into the floor of the mouth. So what to do in this case? If this really ever happens to you, we can really try to immediately place pressure, external pressure, and push that tooth back into the socket and try to recover this tooth immediately. If this fails, we really should abort it and refer to a clinic. Also here, this root tip fracture, dentist tried to recover it, pushed it right into the inferior alveolar canal. Well, of course, we have to verify that. And here, since this was causing a paresthesia, this root tip had to be explored from externally and had to be removed from the inferior alveolar canal. But teeth also can be displaced into the maxillary sinus, especially if they're highly impacted in the maxillary arch. And here, I have more than these 3 examples. I may have 20 of these examples. So it's rare, but still not very rare. And if that happens, how can we recover this tooth? Well, there's a transalveolar approach. That means we can try to recover this tooth through the socket itself, the so-called transalveolar approach. That means we really have to extend the socket, but this may look as a less traumatic approach, but I tell you, this often burns this side for implants. It's going to be very difficult to place implants, high amount of reconstruction necessary. Another way would be to perform a cultural lock. So we have an axis, a larger axis away from the socket, and often once the bone lid is made, we irrigate and the fragment literally is visible and we can recover it. Especially in this scenario when a tooth or a root tip is displaced in the maxillary sinus, we create that cultural lock window. Like in this scenario, you see that root tip was displaced in the maxillary sinus. We used a piezo to create an access window, and literally with the suction tip, it was possible to recover this root tip. And then the nice thing, if we are using this technique, this bone lid can be replanted and fixed, so there is almost no damage on the facial wall of the sinus. Another way to recover it would be an endoscopic approach. FES surgery is certainly minimal invasive, but we have to remove that uncinate process to get access. And sometimes it can be even difficult to see, especially in the anterior aspect of the sinus. Even with this technique, it can be a bit difficult to visualize these root tips. Here, another type of displacement. So what happened here? The dentist said, well, I placed an elevator and out of a sudden the tooth disappeared. So is it in the sinus? No, it's not. It's out the sinus. It's the infratemporal fossa. You see here in the 3D reconstruction, this tooth got really displaced in the infratemporal fossa. And we know there are a lot of blood vessels, venous complexes, maxillary artery, so not an easy thing to do. But in this case, it was able just by extending the incision, making a longer incision, some manual pressure from the back, and we were able to recover this tooth in local anesthesia. But if this fails and we can't see the tooth, well, we can also think about to delay the entire process, put the patient on antibiotics, and recover this tooth in the OR. And different approaches have been described in the literature, but if this kind of situation appears, we mostly rely on navigation systems, virtual reality. You see here that's a scenario to recover this tooth displaced in the infratemporal fossa. So really important. We actually want to avoid this kind of scenarios. You see all the effort which had to be undertaken just to recover this tooth. Another scenario is the tooth is out and then slips out of the forceps. The patient swallows or aspirates it, but at least at that moment, we only see that the tooth is lost in the pharynx. So what we do next? Of course, we observe the patient. Is there coughing? Is there respiratory distress? Yes or no? In case there is, this patient goes right to the ER. I would even suggest at any rate that patient should see the ER. We perform a chest or an abdominal x-ray to localize this tooth. But once the patient is in the chair, it's really important to do the right thing. And the right thing is if that patient has difficulty in breathing, we call 911. We bring that patient to the hospital as soon as possible and apply BLS protocols. If the and even a Heimlich maneuver can be helpful in this situation. Or here, out of a sudden, that screwdriver. Dentists try to put the abutment on. The screwdriver slipped out of his finger and ended up in the throat. Fortunately, this screwdriver could be easily recovered by laryngoscopy with a McGill forceps. But sometimes teeth, extracted teeth, as you see here, they end up in the lung or even here in the abdomen. That's why it's important. Once the tooth disappears in the throat, in the pharynx, we have to localize it. And then sometimes it has to be recovered by bronchoscopy or even by thoracotomy. Of course, we don't want that. Another option would be that the foreign body or the tooth is not aspirated, it's swallowed. If we are lucky, this instrument or the tooth passes through the gastrointestinal tract within 2 to 4 days. But we should always take an exit to make sure that the tooth or the instrument is leaving the body. Because what can happen, like in this scenario, this screwdriver stayed there for 7 days, stayed there for 14 days, and ultimately had to be removed by colonoscopy. So please always use a throat bag when you're dealing with these instruments, especially with these tiny little implant parts and screws. Even if they have an extraction with a restoration on it, our students and residents and faculty are obligated to use that at any rate. A more rare fracture, a more rare complication is the fracture of the mandible. Too much force during the process itself, but also late mandibular fracture due to postoperative osteomyelitis can happen. Fortunately, the incidence, as you can see here, is very, very low. How can that happen? And as you can see in this photoelastic model, there is a lot of stress. If we don't do that procedure properly, we apply a lot of stress during the luxation process when we use our elevator. So if you're working on these teeth, please remove a sufficient amount of bone, section its teeth before you apply that pressure. Because here, that's what happens. You see, that's exactly what I have shown you. You see here, that's where you have the maximum of your stress. That's where your mandible is going to fracture. But as I mentioned, even a post-op infection can cause an osteomyelitis. So the patient, like in this scenario, faced a spontaneous pathological fracture even 4 weeks after surgery. In scenarios like this, we really have to anticipate a potential complication. So if we remove this tooth along with the cyst, we anticipate this. There's a good chance that this mandible may fracture. So we splinted this mandible before we remove the cyst and the tooth. So a fracture, in case it happens, can be easily prevented. Also very common bleedings, intraoperative bleedings, but also postoperative bleedings. If we are facing that, the first thing we should do is to localize the origin of the bleeding. Is it the gingiva? Is it the bony side? Or are we facing even a medical problem? So prevention of these post-op problems is key. Good history, atraumatic surgical procedure, good intraoperative hemostasis are absolutely key. Of course, the local management, like here with a collagen plug, is the most common to do, and I'm sure you guys know all that and do this. So what else can we do? If a bleeding occurs, pressure packs, suturing, hemostatic material are the first things we may do. But also other procedures are available. Like compression of the bone, we can use bone wax, we can burnish the bone, but even sometimes we have to use more advanced procedures like using a bipolar or even have to ligate blood vessels. You see this patient here. What happened here? This patient had a third molar extraction. And it caused a large hematoma, most likely due to a laceration of the PSA or the thyroid process. But this patient, this bleeding could be contained by packing only. Sometimes if we cannot manage a bleeding locally, with local meshes, we also should consider systemic issues. And you see here, a lot of ways are available to control these bleeding problems. But better, if patients have systemic disorders, please try to prevent it before the procedure. You're supposed to take a good health history and understand conditions or medications that can be a risk for bleeding, even if it means that we have to take some labs and get some medical clearance. So please keep that in mind. And there's this other big topic, again, nerve injuries. I think that's one of the major reasons why the GP thinks about referring that patient to the specialist. Especially when we are removing mandibular teeth, especially wisdom teeth, we are dealing with 4 different types of nerve, but it's most likely the lingual or the inferior alveolar nerve which is giving us some troubles. And it's not always only the procedure itself. We also have to think about that the local anesthesia, the local anesthetic agent can even cause a nerve damage. Just by injecting this close to the mandibular foramen, we can cause a rupture of the arteriole. We can inject it literally into the nerve sheath. And we know that certain type of local anesthetic agents are neurotoxic, especially articaine. So in our school, in our environment, we will not do IAN blocks with articaine due to its higher neurotoxic potential. In general, nerve damage to the IAN is rare. Like within the first week, we have a 1 to 5% incidence. And for the long run, like after 6 months, the incidence is really low. And the problem with the IAN is that it's barely noticed during surgery. It cannot be identified during the removal. It always appears post-operatively. Only a very few amount of cases we had where the surgeon could identify a damage. So please keep this in mind. And if you are facing these problems, really document the problems. Take pictures, draw it in the chart, map the deficit, and follow up on it. It's also helpful to understand why these nerve damages occur. Fortunately, in most cases, it's a compression or a stretch of this nerve. But yes, in situations like that, we can literally sever the nerve with our drill. So if we have to section a tooth close to the nerve, should be very careful. And we should always leave a shell of the tooth apically. If this is not possible, or we want to stay away from that, we should also think about alternatives like coronectomy or piezo surgery. Like in this case, by applying a different technique, we were able to recover this tooth all the way around the inferior alveolar nerve, but with the help of piezo surgery, this tooth could be removed. But also other strategies are well known and applied when it comes to the removal of mandibular third molars, like coronectomy, like pericoronal ostectomy, or even orthodontic extrusion should be in our toolbox. Especially coronectomy, or another word, intentional partial odontectomy, is meanwhile a very viable technique in cases when we cannot remove the mandibular third molar without having a considerable risk of nerve damage. So this technique includes only the removing of the crown and leaving the roots in place. For example, in a situation like that, we see we have an intimate relationship between the INN and the tooth, which is confirmed by a CBCT. So we only remove the coronal part. We make sure that the root part is about 3 to 4 millimeters below the crest, and we obtain primary closure, and then we observe. In most cases, there will be no migration, which is considered to be a success. We will have bone formation on top of it on the coronal part. But what else could happen? In these cases, you see a coronectomy was performed and the roots started to migrate. The patient developed symptoms and this tooth had to be removed. But at least at that point, the roots were migrating away from the inferior alveolar nerve. Also, as you see here, orthodontic extrusion of a mandibular third molar help to minimize the risk of a nerve damage. And there are more examples. Very nice publication here from Bonardi shows that the orthodontic extrusion is a viable alternative to a surgical removal. Oral anti-communication, big topic, happens actually quite often, typically wise along with the extractions of first and second molars, but also with third molars. Typically wise, as you see here, first and second molars. How to prevent it? Really good evaluation of our access. Anticipate your complication. Modify your surgical procedures by a proper bone removal and by early and primary sectioning of the tooth. And how to diagnose it? Yeah, well, if you extract a tooth and bone is adherent to the root ends, or you visualize it, or your Valsalva maneuver is positive, then we really should anticipate it. The question is probing of the socket appropriate, yes or no? Well, I think that's kind of a controversy. If you really want to probe it, there is always a chance that you introduce bacterial foreign material into the sinus. So I not generally recommend it, but if you really do it, use the proper instrument like this Baumann Antrum probe, which is a ball-pointed probe. This is, I think, the only proper instrument where we can probe a socket. And if it happens, what to do? I would say it all depends. The best management is to avoid the exposure of the sinus. If it happens, it depends on the size, on the time of the diagnosis. Is there an infection going on? Yes or no? Do we have a good amount and a good condition of the tissue around the oral anticommunication to close it? And of course, are dental implants planned in the future? All these are factors which ultimately determine our approach to an oral anticommunication. In general, if it's acute and small, like less than 4 millimeters, I would close it right away. Have a good blood clot, high blood clotted in the socket. No surgical procedure is required. We need that high quality blood clot. We should prevent any kind of dislodgement. So we explain our patient all the sinus precaution, tell them not to smoke, prescribe antibiotics and a nasal spray. And in most of the time, this is going to heal. If our communication is really acute and large, then a primary closure is definitely recommended. The sooner you do it, the better. You see a early closure has a much higher success rate than a secondary closure. There are lots of techniques available. This is just a brief overview. I can show you some of them. I think that the most common is that so-called buccal advancement flap, or called the Rationale flap. We are mobilizing a flap from the vestibule. Unfortunately, the downside is that this will reduce the sulcus depth, but this can be corrected with a vestibuloplasty. But I think that's the most common way to handle that. See, we do some release incision. We score the periosteum. We make sure there are no bony spicules, no sharp ridges, which can impede our flap, and we close it. I think the second most common flap is here, that palatal rotational flap, but that's more a procedure. If the first procedure fails, more for the late repair, it requires a bit more surgical experience, but it's typically used when our buccal flap was non-successful. As a real alternative to that buccal advancement flap is the buccal fat pad. That buccal fat pad can be easily accessed, placed into our oral anticommunication, and will seal off the communication. Point is really that when we extract the teeth, that we really detect these communications. Because if we don't, we are causing a maxillary sinusitis. We don't want that. And these sinusitis will ultimately cause a chronic antral fistula. And we have to be aware that even small communications have a chance that they do not heal and they cause a fistula. So at least the minimum we have to do, we have to follow up even with small communication. And if this communication persists even after 2 or 3 weeks, it might be better to refer this to an oral maxillofacial surgeon, because this problem has to be addressed. And that's how it looks like. If you see this kind of scenarios, they had an extraction and you see that fistula after 2 or 3 weeks, that has to be addressed. This kind of scenario, well, may look common, but ultimately it's just a post-operative swelling, pain, swelling, trismus. Usually these are just self-limiting side effects, and they completely resolve within several days. You can support it with some steroids, but this usually goes away. Different it is when patients come back after 3 or 4 days and they show up with this kind of thing, this so-called dry socket. I think all of you who extract teeth have faced this problem. It's not really fully understood why it happens, but it's a kind of a delayed healing. The blood clot is getting lost. due to fibrinolytic activity, and it typically wise appears on the third or fourth post-operative day, typically wise in lower molars. Yeah, and you see this kind of pictures. I think we are familiar with that. No clot in the socket. What should we do? The main, and I think the only and single therapeutic goal is to relieve the pain of the patient during the healing. It will heal. As long as the patient doesn't have any comorbidities, it will heal. So we will only irrigate it. We may remove some old blood clots, some debris, but we don't correct it anymore. That's the old school way. We rather place a sedative medical dressing on the carrier, and the moment the patient comes back, doesn't report pain anymore, we remove the dressing, or if we use something resorbable, we leave it alone because everything ultimately acts like a foreign body. These materials, well, there are multiple materials here on the market. Doesn't matter so much what you use, but I always recommend to use like a vehicle, whether resorbable or non-resorbable, to put it in the socket. But sometimes, we have to ask our question, is that really a dry socket? Because these dry sockets, they shouldn't last not more than just like a couple of days. And sometimes patients come back and it's still not good. And then we should think about, okay, if things don't seem right, there's a good chance that something is really going wrong. So that's really, the dry socket is really an early complication, and it should be resolved within a very short period of time. So at least we should think about, yes, it can be a medication-related osteonecrosis if the patient had a history of these drugs. It can be an ORN if the patient had a radiotherapy in the past. But we also should think about, it's not a dry socket, it's a post-operative infection. So especially if we have an increased swelling. A dry socket doesn't have a swelling. So if we see swelling and pain, we see skin erythema, patient has fever, we have to think about a post-operative infection. And this requires a different treatment. We may start with standard antibiotics, but we should also place a drain if the soft tissue is involved, and we may even have to address the socket itself. And sometimes these infections, they spread, and that's where the problem really starts. Like here, they spread into the submandibular space, like in these two individuals, and then, of course, they have to be admitted to an OFS department for an even external IND, which has to be performed under general anesthesia. Also here, just a few teeth have been extracted. After 4 days, patient presents with a deep facial abscess. You see all these hypodense areas extending all the way into the neck. You see here again, and here's a huge abscess just after tooth extraction, of course, that had to be incised and drained under general anesthesia. And if things go south, they can really go south and even cause more of a problem, like this descending mediastinitis. Like this patient should have showed up with a blood count of 22,000 and more, and we see an involvement of the thoracic space of the mediastinum. This is a life-threatening condition. So all clinicians who perform exodontia should be really aware of these clinical signs like fever, dysphagia, redness, swelling of the floor of the mouth. These symptoms must really alert us, because we should keep this in mind, that things can really go south, and even a simple dental abscess can make it all the way through the retropharyngeal space, through all these deep facial spaces into the mediastinum, and gravity and negative interthoracic pressures are supporting the migration of these infections. So please be aware and be alert, because we don't want to see our patients ending up like that, because that's how a descending mediastinitis is ultimately treated with surgical drainage on multiple sites, systemic antibiotic therapy with different drugs, and of course these people need a supportive medical care. This is a life-threatening condition. What goes south may also go north, like in this 40-year-old female. She only had an extraction and a socket graft done, but then about 8 days post-operatively, she presented with a temperature of 101 degree Fahrenheit, diplopia, dilated pupils, and an abducens nerve palsy. So that was really weird. And if you ever see this, the diagnosis is clear. This patient, of course, had a cavernous sinus thrombosis. How can that happen? We have to be aware that all kinds of infections, odontogenic infections, which appear here in that danger triangle, they can make it all the way up into the brain because there are no valves in these veins, and through an anterior or a posterior route, they can ascend into the cavernous sinus and cause another life-threatening condition. So we clinicians, we really should be aware of at least of some basic clinical symptoms like fever, headache, ptosis, and especially all kind of ophthalmoparesis, especially of the cranial nerve number 6, the abducens. This is a pathognomonic sign of a cavernous sinus thrombosis, and this should absolutely alert us. So I want to summarize for you. It's like oral surgery, big picture. If you perform oral surgery in your office, please, before you cut, have a plan. Really anticipate complications. Run through different scenarios, always at your personal comfort level. And if it happens, please always full disclosure to the patients. You may refer them. I hope I was able to show you in my lecture that even simple oral surgery procedures are always invasive in nature, and they can trigger extremely serious and sometimes even life-threatening complications. And no matter what, whether you're an oral surgeon or a dentist, no matter how skilled and experienced you are in oral surgery, at all times we have to be aware of complications, and we have to have a plan in case of emergency so we can intervene. I'm at the end of my lecture. I hope I was able to highlight this important topic for all of you, and thank you again for your attendance, for your help to make this happen. And I say goodbye from New York, and I hope you really enjoy the rest of our meeting.
Dr. Thomas, that was an excellent presentation as usual, and we much appreciate it. Let's see if we can get a little bit more into the scenarios that you have had. At what point would you suggest a general dentist running into troubles seeking the advice of an oral surgeon or a periodontist or a specialist of some kind?
I think the moment the GP or the provider is no longer comfortable, it means it's different for everyone. It can. I know you kind of a very long time, and I know your comfort level is quite different than maybe somebody else's. As long as you have the feeling that you cannot handle it anymore, also that your facility, the facility you're working in, is not capable to give proper care for this patient, that's the moment when you should contact an oral surgeon or even a clinic facility. It can be really different for everyone. The skill sets are so widespread. The knowledge is so widespread that I cannot actually give a recommendation. It really depends on the individual comfort level. Better call early than too late. That would be my. Never too late. Never too early.
Well, this was an amazing lecture as usual. We are going to be having the next lecture in about 10 to 15 minutes. To reiterate what we have discussed at the beginning of the show, that you are welcome to join Dr. Wiedemann and do more of hands-on type scenario with us. If you wish, I'm going to put this back up, Doc, so we can look at the particular opportunity, and there we would be doing a little bit more hands-on and discussing a little bit more of the complications management scenarios with different hands-on procedures and cadavers. We invite you to come out. July 31 is the first time you're starting the International Extraction Academy workshops back up. As to CE, if you like to get CE for the session, and the code again is AOS 2021 and EXT Academy under registration area, you can register for those. As to CE for this session that you just attended, there will be in the chat box, we're going to put the information on how you can get registered. It just showed up on the right by the executive director, Ms. Schultz. You click that and you follow that and you claim your CE, and this will happen at every session this weekend and moving forward on the weekends with the Podinars, so you can come in and do that. Another question just came in, Dr. Wiedemann. Where should we place our incision in the case of submandibular abscess drainage? I presume he's contact with bone would be necessary, but perhaps you can elaborate on that.
I'll be happy to explain it. No, actually not on bone. It's the golden rule is really, you take your two fingers. You should be about 2 fingers away from you, from the inferior margin of the mandible. You palpate that. Don't forget, there is one branch of the facial nerve, and we want to stay away from that. So the typical incision is within the skin lines, about 2 fingers away from the inferior border of the mandible, and you only incise through the skin itself. Once you made the incision through the skin, then you prep all the way through towards the mandible, but this with a dull instrument, not with sharp instruments. So no scissors, no scalpel. Yeah. You literally spread the tissue and you approach the mandibular spaces. Once you reach the bone, then you can open up masseter space or the submental or the submandibular space. Yeah. So the incision, 2 fingers, and you only incise through the skin, not all the way through to bone contact. Please don't do that.
No, ma'am, I misunderstood the question. I thought it was just your general abscess that you have on a buccal of a tooth. Submandibular space is a very dangerous space, as you mentioned, the facial nerve coming up and wrapping around from underneath. I think that you could cause serious damage in the submandibular space that could be life-threatening, considering all of the vessels that run through there. Fantastic. So, do you recommend actually putting a drain in and suturing that in, or you just are you one of those guys that says they leave it open and kind of let it heal up?
Okay, good question. Well, let's say in small abscesses, you make the incision and you're probably good to go. But if a lot of pus is draining out, I will definitely place that drain and always fixate it with a suture. Plus, bring that patient back in the next day. So you want to see an improvement. But in general, I would place the drain unless there is barely any pus. Small periodontal abscesses, they may not be drained with a drainage. An incision is usually enough. But a larger abscess, I would always place the drain, fixate it, and bring the patient the next day. And your expectation is that the patient significantly improves. If the patient does not improve, this would really start your thinking process. Your incision might have not been deep enough. There might be another chamber of that abscess. So it's really important to follow up. Good incision and a really observed drainage. You have to see the pus. If you don't see the pus, bring him back. The patient should always significantly improve within 24 hours.
Excellent. Fantastic. So, Doc, we're going to be monitoring this thread closely because people are going to continue registering for their continuing education hour. And if there are questions that will continue to be posted, please respond to them on this thread. It will be a sole standing thread on this page. And will also be able to be found in the video section. If you guys want to watch any of the videos over to get the additional information, you can go to this Global Summits page, and what you see here will be under the video section. You will find all of the videos, and you can watch them and earn your CE that way as well. So this one will be particularly listed right here, and you can click on it and get the CE that you need. Very good. So, Dr. Wiedemann, I'd like to thank you for taking the time to donate knowledge and information to our colleagues from across the world that will be watching this in the next 24 hours in all time zones that we are familiar with based on our historic studies. And we look forward to the next session, and we have 2 more global symposia coming up this year with the AOS. And thank you for the first session of the day with complications management.
Thank you very much, Dr. Shah. Always a pleasure to be with you, and I hope I could help a little bit, and I wish you a great day and a great time with our summit here.
Thank you so much.
Goodbye, everyone.
Bye-bye. Next session will start in 10 minutes. Thank you, and a small coffee break.